Okay, so let's unpack this. Imagine you are trying to review the side effects of a brand new fire extinguisher.
Well,
But you are only allowed to ask people who are currently standing inside a burning building.
right.
Like, if they tell you they feel incredibly anxious and miserable and exhausted, is it the fire extinguisher's fault, or is it the massive fire surrounding them?
Yeah, that analogy really hits the nail on the head. Because for decades, that is exactly how the medical community has studied the relationship between birth control pills and endometriosis.
Welcome to the deep dive, by the way.
Yes, welcome.
Today, we are bringing you right to the cutting edge of a massive, long-standing, and honestly very heated medical debate.
It really is.
If you have endometriosis, or if you know someone who does, or even if you are just, totally fascinated by the intersection of women's health, neurobiology, and data science, this is for you.
Absolutely. We are looking at a highly anticipated 2026 systematic review published in the Acta Obstet Gynecol Scand. It's by Salmeri and a team of researchers out of Milan.
And the focus here is on the international first-line treatments for endometriosis, right?
Right.
So combined oral contraceptives and progestin-only pills.
Exactly. The clinical goal of these pills is pretty straightforward. They are meant to suppress ovulation and stop what we call retrograde menstruation.
Okay.
That's when blood flows backward into the pelvis, and that creates a highly inflammatory environment. So by stopping that cycle, the pills aim to reduce the physical burden.
But pop culture, anecdotal reports, and, well, a whole lot of older studies have painted a very different picture of what these pills actually do to a patient.
Right, there is a deeply ingrained narrative out there.
Yeah, this narrative that hormonal contraceptives inherently cause depression, severe mood swings, and just entirely tank a person's libido. So you have patients already suffering from a really painful disease, and they are handed a pill that they fear might ruin whatever is left of their mental and sexual well-being.
Which brings us to the core dilemma Salmeri's team wanted to solve. Are the pills actually causing the psychological and sexual dysfunction, or is the brutal reality of living with unmedicated endometriosis causing it?
To figure that out, we really have to look at how past research messed this up. Thinking back to those older epidemiological studies,
Yeah.
if you are in severe chronic pain every single day of your life,
Of course you are going to experience depressive symptoms.
right, of course your libido's going to drop. It's like trying to figure out if a new brand of rain jacket makes people miserable, but you only test it on people standing outside in a freezing hurricane.
That's exactly it.
How did researchers ever think they could isolate the side effects of a pill from the sheer misery of the disease itself?
Well, they couldn't. And that methodological flaw has plagued this research for years. Previous large-scale studies often grouped all women taking birth control into one massive bucket.
Just everyone together.
Everyone. They mixed healthy 19-year-olds taking the pill purely for contraception with 30-year-olds taking it to stop agonizing pelvic pain.
You cannot compare those two experiences. A healthy teenager's baseline mood and sexual function are going to look entirely different from someone navigating a chronic illness.
Right, their baselines are fundamentally incompatible.
They really are.
And stripping away that incompatible baseline is precisely why this 2026 review is such a huge breakthrough. What's fascinating here is that Salmeri and her team leveled the playing field. They threw out the healthy controls entirely.
Wow, completely threw them out.
Completely. In this review, they only included reproductive age women who were specifically diagnosed with endometriosis. They then directly compared the endometriosis patients who are using hormonal treatments against endometriosis patients who are not using any hormonal treatment.
So they finally isolated the variables. We have a clean environment to test the fire extinguisher without dragging healthy people into the burning buildings.
Exactly.
So let's look at the actual data they uncovered, because they started with a ton of papers, right? How did they sift through all the noise to find reliable numbers?
They started with a mountain of over 1,400 published records. But they didn't just accept any study. They applied incredibly strict filters to weed out biased data, poor methodology, incomplete reporting.
All the junk.
Yeah, all the junk. And they brought that mountain down to just 7 rock-solid, highly rigorous studies. That's 4 randomized controlled trials and 3 observational studies.
Now, 7 studies might not sound like a massive number to you listening, but in the world of highly controlled systematic reviews, finding 7 clean, comparable studies on a specific subset of patients is a total goldmine.
It absolutely is a goldmine. But even with those 7 pristine studies, the researchers faced a major mathematical hurdle.
Because they use different tests.
Right. These studies measured psychological and sexual outcomes using entirely different questionnaires. One study might use a generalized 36-point health survey, while another used a highly specific index for female sexual function.
And another just tracked adverse medical events reported to doctors, I think.
Exactly. Because the measuring sticks were so fundamentally different, mashing all those specific numbers together into a traditional meta-analysis would have produced mathematical garbage.
Wait, so if they can't pull the numbers together, how do they actually find a consensus? The source mentions they used a Cochrane-recommended method called vote counting by direction of effect.
Yes.
And I have to push back here because vote counting sounds a little unscientific. I mean, are they just tallying up good vibes versus bad vibes instead of using hard clinical data?
I know it sounds very colloquial, but it is actually a highly validated statistical tool designed exactly for this scenario.
Okay, how does it work?
When you can't combine the raw numbers because the units of measurement are different, you standardize the direction of the outcome.
Direction meaning positive or negative?
Yes. Regardless of the specific questionnaire used, did the intervention push the patient's well-being in a positive direction, a negative direction, or did it have zero effect? It creates a binary metric that allows you to responsibly compare a mood survey with a sexual function index.
All right, that makes sense. You are looking at the trajectory rather than the exact coordinates.
Precisely.
So drum roll, please. When you look at the trajectory for these endometriosis patients, what is the final verdict?
Out of the 7 studies, 6 of them, which is an 86% pooled proportion, found absolutely no increased risk of psychological dysfunction in the patients using the pills compared to the non-users.
Wow.
And when it came to sexual dysfunction, the results were even more definitive. 100% of the studies reported no increased sexual dysfunction in the pill users.
Here's where it gets really interesting, though. Because the patient-reported outcomes didn't just show that patients simply didn't get worse. In many cases, the scores for mental health, emotional roles, and social functioning actually got better. And specifically regarding sexual health, so desire, arousal, lubrication, and orgasm scores, they actually improved while on the pill.
And that improvement points directly to the mechanism of the medication. The pills were successfully suppressing the disease. 6 of the studies specifically measured outcomes for dyspareunia, tracking the severity of pain during sex. All 6 reported a significant reduction in pain. By chemically suppressing the cyclic inflammation and preventing that retrograde bleeding we talked about, the physical burden of the disease was lifted.
An 86% success rate is amazing, but, if I'm a patient, my eyes are glued to that remaining 14%.
Naturally.
We cannot just ignore the outlier. There is one study in this review that practically validates everyone's worst fears about the pill. So how do the researchers justify that glaring contradiction?
Well, if we connect this to the bigger picture, that 7th study requires a deep dive into its design. It was a retrospective register study that looked backward over 12 years of patient records.
Okay.
And unlike the other 6, it did find a significantly higher risk of mood lability and depression in pill users, reporting a 1.79 relative risk.
And a 1.79 relative risk is almost double the baseline risk.
Yeah.
That sounds terrifying if you are a patient Googling your medication and you stumble onto that specific paper.
It sounds scary.
Why did the patients in that one study fare so poorly?
Well, the reviewers noted that this specific retrospective study carried a serious risk of bias in how they classified confounding factors. But the smoking gun, the most revealing detail, is the symptom relief.
What do you mean?
In this outlier study, an absolutely staggering 52% of the participants reported inadequate symptom relief.
So half the people in that study were taking the hormones, experiencing whatever systemic changes those bring, but still suffering from the agonizing daily pain of endometriosis.
Exactly.
The fire extinguisher wasn't putting out the fire.
That is the central piece of the puzzle. It reveals the most vital insight of the entire systematic review. When the studies showed that the pills successfully achieved pain remission...
Like when they actually worked to stop the physical agony?
Right. When they worked, the rate of patients discontinuing the treatment due to psychological or sexual adverse events was literally 0%.
Let me repeat that for you because it is a massive paradigm shift. 0%. When the physical pain of endometriosis was successfully chemically cured, no one quit the drug because it ruined their mood or their sex life.
And to understand why that is, we have to look at the neurobiology. Pain and depression are not just loosely correlated concepts where being in pain makes you feel sad.
They're more connected than that.
Much more. They are biologically intertwined, they share common genetic factors, and use the exact same molecular pathways in the brain.
So it's not a purely psychological reaction. You are saying that chronic pain physically alters the brain in a way that manifests as clinical depression.
Yes.
How does that actually work mechanically?
When you are in a state of chronic, moderate to severe pelvic pain, your central nervous system is bombarded with distress signals. Over time, this constant firing alters your brain's neuroplasticity.
It changes the brain's wiring.
Exactly. It depletes crucial neurotransmitters like serotonin and dopamine, which are the same chemicals responsible for mood regulation. This creates an environment where anxiety and depression thrive biologically. So by using the pill to chemically switch off the physical pain, you stop that bombardment. You are simultaneously alleviating the biological burden on the brain's emotional centers. Curing the physical pain chemically cures the mental burden.
We so often treat the mind and the body as these two totally separate silos. You go to the gynecologist for your pelvic pain and you go to the therapist for your depression.
Right, very separated.
But this data is screaming that they are essentially the same fire burning in two different rooms of the house. Put out the fire in the pelvis and the smoke clears in the brain.
It is a beautifully integrated way to look at human physiology. However, we also have to recognize that the physical makeup of the pills themselves does interact directly with the brain.
So we can't just ignore the hormones themselves.
No, we cannot just say the pill is fine as long as it stops the pain. We have to look at the chemical nuance because the specific hormonal ingredients matter immensely.
Right, because pop culture treats birth control like it is just one monolithic thing, like, oh, I'm going on the pill. But the source text really highlights that the specific recipe of the pill, the exact ratio of hormones, determines how your brain reacts to it.
This raises an important question about the differing effects of estrogens versus progestins. Generally speaking, estrogen acts as a neuroprotective agent.
Okay.
It interacts directly with serotonin receptors in the brain, promotes synapse formation, and helps stabilize mood. It basically acts as a buffer.
And the progestins.
Progestins, on the other hand, specifically synthetic progestins, have a very different mechanism.
How do they alter the mood centers?
Well, synthetic progestins can increase the activity of an enzyme called monoamine oxidase, which actively breaks down serotonin.
Oh, so it's removing the serotonin.
Right. They also modulate GABA receptors in a way that can leave some patients feeling sedated or depressed. This isn't just theory either. It is backed by decades of data.
Yeah, the review mentions FDA pharmacovigilance data, right?
Yes. Over a 20-year period, that data identified over 6,500 cases of progestogen-related depression.
So if estrogen is the buffer and progestin is the potential disruptor, what happens when you mess with that ratio?
We actually saw this play out historically. Prior to 1969, birth control pills had much higher doses of estrogen, but high estrogen carries a risk of blood clots.
Which is obviously very dangerous.
Exactly. So to make the pills safer for the cardiovascular system, pharmaceutical companies drastically lowered the estrogen doses.
But by doing so, they inadvertently removed that neuroprotective buffer.
Yes. Reports of depression and anxiety actually increased with those lower estrogen formulations because the synthetic progestins were left unchecked.
Which is such a difficult balancing act for drug manufacturers. You fix one life-threatening risk, and you inadvertently elevate a psychological one.
It's very complex.
So how does this apply to you, the listener, or someone you know who might be navigating this? Because if a patient with endometriosis is on a pill and they are experiencing severe mood issues or a tanking libido, it might not be the sweeping conclusion that, birth control is bad for me.
Right.
It might simply be that the specific type, the specific ratio of hormones is wrong for their unique neurochemistry.
The review heavily emphasizes this point. The type of estrogen matters significantly. For example, newer formulations that contain bioidentical estradiol, which chemically matches what your body naturally produces, appear to be much better tolerated for mood than the older synthetic ethinyl estradiol-based pills.
And the route of administration matters too, right?
Oh, definitely. The reel modulates how the hormones are metabolized. If one pill causes mood side effects, it is highly likely another formulation might control the pain without the psychological toll.
It's about optimizing the recipe for the individual. But let's say a patient works with their doctor They optimize the pill formulation. Maybe they switch to a bioidentical estradiol. The pain is mostly gone, but they are still experiencing lingering sexual dysfunction or mood issues. Does the road end there?
It absolutely does not. Endometriosis care is rapidly moving beyond a one-size-fits-all approach. We are looking at integrated, multimodal care.
What does that look like in practice?
Well, for instance, pelvic floor therapy can be life-changing for sexual dysfunction. Years of agonizing pelvic pain often cause the pelvic floor muscles to chronically spasm and guard, essentially locking up.
Oh, wow.
Yeah, so even when the chemical inflammation is gone, the muscles are still traumatized. Physical therapy physically releases those spasms.
So you are treating the mechanical aftermath of the chemical fire.
Precisely. And for the mental aftermath, cognitive behavioral therapy is highly effective for managing the psychological weight of chronic illness.
And there are technological approaches too, I think.
Yes, there are advanced techniques like neuromodulation, which uses electrical impulses to reset the nerves that have been hypersensitized by years of pain. The goal is lifelong well-being, utilizing every tool available, rather than just forcing a patient to endure a side effect to treat a symptom.
So what does this all mean? Let's bring all these threads together.
Yeah.
If you take away one thing from this deep dive into the 2026 Salmeri Review, it should be this. The widespread narrative that hormonal contraceptives inherently and inevitably ruin the mood and sex lives of endometriosis patients is largely a myth built on flawed data.
That's the main takeaway.
When the pills are optimized for the individual and effectively stop the pelvic pain, mental and sexual health do not crash. They generally stabilize, and very often, they actually improve.
The current high-quality evidence simply does not support a consistent increase in negative psychological or sexual outcomes when medication is doing its job. It completely reframes how we view chronic illness and its treatments.
It is about giving the patient their life back, in every sense of the word. Thank you for joining us on this deep dive. We've untangled a lot of complex data today, but I want to leave you with a final, somewhat mind-bending question to ponder.
Oh, I love these.
We spent a lot of time talking about how chronic pelvic pain and depression share the exact same genetic factors and molecular pathways in the brain. They use the same neurotransmitter systems.
They do.
If that biological link is so profound, could the future of treating endometriosis not come from a gynecologist at all? Could it come from a breakthrough in psychiatric neurobiology?
That's a fascinating thought.
Right, if the physical pain and the mental depression are truly the same fire burning in two different rooms, could the ultimate cure for this reproductive disease actually be hiding in the brain?
It's certainly possible.
Something to think about. Next time you find yourself trying to evaluate a tool, make sure you aren't just measuring the storm around it. Until next time.